Then, yeah, let's go ahead and get started then. Dr. Johnny Wu is going to be our presenter today our presentation is going to be on medical directors, best practices in a correctional medicine setting. I've had the honor and the privilege to know Dr. Wu during the Correctional Medicine Fellowship Program and learned a lot of leadership from him. So very delighted, and I think we're all going to have a really good evening learning from you today, Dr. Wu. So the stage is yours, Johnny, and we look forward to your presentation.
Thank you, Susan. So, Dr. Prini asked Dr. May and myself to do this presentation around best practices in a correctional setting for medical directors. Unfortunately, Dr. May is not available to attend. So, again, as I said earlier, you only get half the presentation. I'll do my best to try to fill up this time. So with that, I'll just go into I have nothing to disclose. And learning objectives, we're just going to be talking about some of the fundamental responsibilities of what a site medical director is responsible for doing, as well as a regional. And I'm also going to talk about a little bit differences about how, like on a DOC client side of medical directors, because each one is a little bit different. And then I'm going to also talk a little bit about the culture of the prison system and how you have to kind of model yourself to that system. And also just talking about some of the pitfalls, because I think a lot of folks just don't really realize the significance of legal impacts of being a medical director. So first off, I want to talk about loyalties. So in the academic world, we talk about dual loyalties, but in, I think our setting, I think it's a little bit more complex than just dual. So I kind of just unofficially call it the quadruple loyalty. So obviously we have an obligation to make sure that we do what's in the best interest of our patients. We also, because we are employed either through the state or through a private contractor vendor system, that we also have loyalties to our employer. And then if we work for a third-party vendor, obviously there's the loyalty to the client, which usually is the Department of Corrections or a sheriff or a warden, depending if you're working in a county jail system versus a state DOC system. And then lastly, our own personal ethics and politics, we need to kind of keep that in check as we look at how we deal with each of the other competing loyalties. In terms of responsibilities, a lot of the responsibilities are kind of set in NCCAC standards as well as ACA. So I'm just going to go over through a few, but the ones I have in the highlight, I kind of want to spend a little bit more time just talking about. So obviously, the first major responsibility is that you need to understand that the difference between a staff physician and the site medical director is that ultimately you are the one responsible for the clinical care at that facility. So you may have folks who report to you, whether it be a staff physician or a physician assistant, nurse practitioner, as well as the rest of the integrated team, nurses, mental health professionals, dentistry, and pharmacy. But at the end of the day, the site medical director is ultimately responsible, especially when the warden is asking about, what we're doing about a certain situation, or if in a situation where unfortunately you're under a class action or consent decree, ultimately you're the one that has to kind of report out to the courts. Another major responsibility is you'll be chairing a lot of administrative meetings. So normally with staff physicians, you tend to just go about your day as providing direct patient care. You may occasionally be interrupted because custody may have wanting something to be explained to them, or some emergency arises and you need to kind of respond to that. But the great majority of the time, staff physician is direct patient care versus a site medical director. You're going to be spending half the time doing administrative duties, and the other time you will be doing direct patient care. And some of these administrative meetings on a monthly basis or quarterly is what we call MAC meetings, medical audit meetings. You go over statistics about, how did the month go with terms of number of people being processed coming in the system, how people have been released. And also we talk about deaths, we talk about referrals, transfers going to the hospital. So these are all important statistics that the site medical director needs to be aware of and to kind of preside over when presenting to the other disciplines as well as to the custody leadership there. We also need to be able to do check-ins with our staff and perform peer reviews. So the staff physician normally, they may have some kind of collaborative agreement with a mid-level provider of some sort, and they will also do their own type of clinical reviews. But the staff physician and the site medical director, it's a little bit more different. In terms of peer review, you're looking overall at the whole system of not just the patient care, but also making sure the operations and everything is appropriately handled as well, not just purely clinical, but it's also more of an administrative review of the performance of the staff members. And there will be usually monthly or quarterly types of clinical meetings where you will be going over cases, discussing with them about maybe new clinical guidelines as they get updated in your system. So those are important to have those routine check-ins as a medical director. Clinical huddles. So this is something that I noticed that we kind of lack in our systems. We tend to be in our own silos. So when I first became a medical director, I always made sure that I got to know who my medical folks were, as well as my mental health and my dental folks. And I routinely would have lunch to meet with the mental health leads and also the dental health leads, so that we ended up having kind of an unofficial huddle. But nowadays, it's really much simpler than lunch. You can just have a 15-minute interdisciplinary gathering just to go over the day, like anything important going on the mental health side, anything going on the dental side, anything medical can help, and just bringing all the leadership together to kind of just go over the day. And so that's something I strongly suggest folks try to do. I mean, sometimes it's a hurdle because the schedules don't overlap. Dentistry may be busy in the morning doing procedures and seeing patients, and mental health maybe in the afternoon. So do your best to try to work. It doesn't have to be in person, but as somehow you're able to, get together and talk even by phone, at the minimum. Also, one of the biggest responsibilities that medical directors need to do, and it's mainly more with regional medical directors, is reviewing the clinical guidelines. The ideal situation is, as new guidelines come about by recommendations from various medical societies and authorities, is that you would review and then maybe adhere or incorporate those newer guidelines, and they need to be signed off by the medical director for the facility, and then make sure that each of the staff members are aware of the new changes. And so it's highly suggested that when new guidelines come out and policies are written, that there's some kind of education at a staff meeting, and there's some kind of notation or like a log sheet to demonstrate that it was educated and provided to the line staff. And if your facility is under the NCCAC or ACA accreditation process, that they're going to ask you and find out if you are indeed reviewing clinical guidelines, and they'll ask for actually specific documentation to show that you actually signed off on it. I mean, back in the day, we all had these big fat manuals that we always have to write in, and then the cover sheet, there's a signed sheet that says, oh yeah, I reviewed the whole 900-page document. Nowadays, it's a lot simpler. You can have a PDF that's available online and just sign off on that PDF. But back in the day, you had to physically carry around this big tome of a book. Now, I want to spend a little time about CQI. I think this is really important for medical directors, because this kind of shows what kind of culture you're going to have. The facility has the day-to-day obligation of taking care of patients, making sure everyone's safe, and there's always room for improvement. No system is perfect. There's always going to be something that you need to look at, and it can be simple as just looking at, is the timing of medications appropriate to ensure adherence? Looking at maybe your sick call process, or why you're not able to see all your patients who sign up within 24 hours to get a triage, and then 24 hours later, a face-to-face. Those are common CQI studies. I would suggest that you really talk to your staff and find out what are the issues for them, especially if it's interfering with how they're able to function. And those should be considered to be looked at as CQI studies. You don't need to have many of them, but you really should be looking at the local problems for your site. I know a lot of private vendor systems, and I'm guilty myself, working for a private vendor, that we have our own corporate CQI studies. And so you may have to do, additional studies to satisfy the corporate needs as well. Performing healthcare reviews. I myself think this is very important because as a person who also functioned as a previous site medical director, I also had opportunities to work as a consultant and as a monitor for clients. And one of those things was always to look at charts. And when I look at charts, sometimes I cringe because the documentation there isn't really consistent with what I know is going on. And, if you're a site medical director, you're going to be asked, what's the deal? And, if you don't do these chart reviews and get really understanding what your folks are documenting, you're going to look silly. So I would suggest that routinely, you don't need to seal the name, but be just consistent. Every once in a while, look at a couple of charts so you get a real feel of what's going on in your system and what's being documented, and be able to correct things sooner than later. M&Ms and psychological autopsies. If your facility has a lot of mortalities and you find out that these are not natural, I would say you need to bring in custody involvement as well to discuss of potential improvement processes to resolve this. But if your facility is one of those where you tend to have the end stage folks, the people who you kind of anticipate death, you can be a little bit more lenient with your reviews. But I suggest the first thing that you look at is, the circumstances around the response to a code. But then you also need to go back at least a year to really look at the care, if it was appropriate, if there was something that was kind of been preventable even early on. A lot of folks tend to just kind of focus on the more recent stuff and then sign off on it. But if you really, really are wanting to make a difference in the care that's being provided, I would suggest doing a little deeper dive and going back. Your clients are going to want you to do a deeper dive, and sometimes you need to really do that to build that trust with them as well. Education. We're all physicians, but we're also educators. We educate our patients, we educate our staff, but also we need to educate custody. So as a medical director, it's your obligation to respond to the callings of the custody folks and to really educate them of what's clinically appropriate, because they don't know. That's why they have you there. So, be a little bit patient with them, because a lot of times you need to be able to speak to their level or go into a little bit further detail, because a lot of the language and acronyms that we use, they don't quite understand. So understand that you need to tailor your education appropriately to your audience. Utilization management and review for medical necessity. So if you're like a regional medical director or statewide medical director, you may have the additional responsibility of being a gatekeeper. And so when folks at a facility, find themselves needing a higher level of care, and your staff write requests for, say, an offsite trip, or maybe needing some higher level of care elsewhere, that there's some kind of process that allows them to do that. And it usually ends up going up to someone like a regional medical director to review those requests. And I would hope that folks who are doing that type of responsibility have some kind of template in place to be consistent, because you don't want to play favorites with any particular facility. How you treat one patient at facility A, should be consistent with the patient B at the next facility. You don't want to set yourself up for scrutiny and risk by not being consistent. And in my own system, we use interqual guidelines, and also we have our own business rules that we apply across our enterprise. So that kind of helps us as medical directors, because it's so hard to be able to make sure that what's medically necessary, because it constantly changes too in this day and age with all the things going on. what used to be medically necessary 10 years ago may not be appropriate at this time, and vice versa. Interqual is known standard for a lot of insurance companies. So that's what I would recommend if you had the opportunity to get trained in Interqual. It's usually a 2-day training. I don't know how much it costs these days, but back in the day, unfortunately, it was quite expensive. And so you should really ask your, I guess, leadership or your corporation or someone higher up, in the admin side to sign off on allowing you to get trained. Because like I said, I think back in the day, it was very expensive for that type of training. Reviewing non-formulary requests, that's something that we need to really look at these days, given the cost of all these new biologics and on all these new fancy, novel, innovative drugs that are just so expensive it blows our budgets. And you need to be able to review the requests and make appropriate alternatives that are just as efficacious. So that's something a medical director really needs to work on, and it can sometimes take up a lot of your day, unfortunately. So just, if you train people and educate them about a particular drug and how the requirements are to be able to approve it, that goes a long way, so that you don't keep getting the same request over and having to deny it over and over and over again. Managing schedules and coverage. So some programs, they utilize the staff to provide on-call services. And so the site medical director usually has to make the determination who gets, the holidays off and who's covering. So that's something that you need to consider. And you really need to be consistent, be fair to everybody. I know sometimes if your system uses union workers, then you had to adhere to the union rules, which to me is not always fair. But you gotta follow the rules if that's what is in place. Grievances. So we all have to deal with this. The DOC has the process of being able to allow patients to file grievances, and so there are timeframes to be able to have them addressed. And so be mindful of what those timeframes are for your facility, because you don't want to fall behind on that, and because there's serious ramifications if you do not, because then it allows them to be able to then proceed to the next higher level. And you usually want to be able to nip this in the bud before it goes out to like the courts to then potentially turn into a lawsuit, like a habeas court. And then getting to courts. So some facilities, unfortunately, you may be working at or potentially work at under consent decrees, class action settlements, court orders. And so usually there are monitors in place. And so you will be the liaison to those court monitors. And you need to develop a good rapport with them. You need to build trust. Understand that they're there to work with you. You should not be adversarial in any way. But sometimes I know that they could be asking a lot of you, but don't take it personal. They got a job to do, and they have to satisfy the judge too. And understand they're really, at the end of the day, on your side. So, if they ask for certain things, do your best to work with them. Sometimes I know that you don't have the information to share with them, and do your best to provide them whatever is needed. So daily task, and I was just thinking of like, what are some of the things that I do when I used to be a site medical director? Is one of the things that I always think of myself, I wouldn't ask someone to do something I wouldn't do myself. You need to set the example for others. You're a role model for everybody at that facility, not just for your staff, but also for the custody, because at the end of the day, you got to work with them as well. And so by being firm, fair, and consistent, you actually win a lot of street cred with everybody. One of the biggest things operation-wise is you got to ensure that sick call is being done every day. I mean, I know it sounds monotonous, but a lot of times emergencies happen, things happen that just unpredicted, and for whatever reason, sick call doesn't get done. Well, you need to be on top of that and try to figure out some way to get it done at the end of the day. I mean, sometimes, you just can't, and then you got to ensure that someone is behind the scenes rescheduling these people and not just let it fall off. And then folks will generate more sick call requests. And then that just kind of snowballs into where you're playing catch up all the time. You don't want it to get to that point. So I suggest, on your to-do list every day is to make sure that you follow up and see that sick call is being performed and caught up on. And same thing goes with off-site trips too. Sometimes you have limits. Custody doesn't have the transport because, since COVID, it's been difficult to have staffing, not just on the medical side, but on the custody side. And so you need officers to be able to transport, but also at the hospital side, the clinic side, they also have limited number of hours available for your patients. So really do your best to stay on top and making sure those trips are happening timely. And one of the things that I would also suggest is that if you have the ability to, is looking at your list every day of trips and being able to have some backup patients to slide in. Say if a patient refused that morning to go see the cardiologist, well, you know what? If you can be flexible and don't lose that slot, slide in the next guy that was supposed to be scheduled to go or something like that. So you don't end up wasting a slot like that. Also, you should get to know your community hospital, your ER, that you should be able to pick up the phone and call and talk to your specialists, talk to your ER docs, and they should know you and what to expect. And it also helps with discharge because a lot of times, they may not know us very well and they'll hold on to our patients. And of course, custody and the bottom line can be affected by that. So it's always best to be able to build that rapport with your community providers. And it goes a long way with the bed management, because a lot of times if you don't communicate, and they discharge someone and then, they arrive at your doorsteps and then you realize, oh, I don't have like a CPAP or BiPAP. If you were regularly in communication with them, you kind of already know what the discharge plan is and what you need to have set up in place to receive them back. Another thing that I used to do routinely when I came into work was also go check in with my farm tech and ensuring that our stock medication par levels were appropriate and accurate, and the counts with the narcotics, because ultimately it was my DEA license as I'm the one that's ordering the stock narcotics. So I want to make sure that everything is up and up. And then again, the huddles, checking in with the other disciplines is what I did each morning. Another thing that I think is really important to know is emergency response. Since we can never predict what's going to happen each day, I mean, we can try to, get through the day without anything, but emergency codes happen, disasters. So really know your emergency response plan, work with your wardens on that. A lot of times they may not want to share with you the emergency response plan because they always claim it's confidential, but really push to really know what that is. You need to know what plan B is. Like, for instance, if a hurricane was coming, what is the plan? What will trigger us to move people to another facility? So I suggest, you have an obligation to your patients to ensure their safety and well-being. So it's important for you to also know what the emergency response plan is for your facility. And also, I like to just kind of walk by and look at the emergency go bag, and also making sure the AED is working properly with the battery properly charged, and also the appropriate pads are in there. Because a lot of times, after an AED is discharged and used, a lot of times people forget to put in fresh pads, and also making sure that the AED is properly charged for the next emergency that may happen, right afterwards. What I enjoyed doing as a medical director was every once in a while we plan and have our own man down drills. And the reason why I like doing that was because I wanted people to have this reflex, this muscle memory on how to respond to a code. So you don't have this deer in the headlights look, because a lot of times, our nurses, they change over. You got nurses who are like those travel nurses and they don't know your procedures. So it's really important for you to keep doing a lot of drills so it becomes really muscle memory. One of the things that used to kind of freak out the custody folks, I used to do codes with the warden being also part of the man down someplace. And that, I think, will actually help endear them to understand how important their role is too in responding to codes, because it could be one of their own people that's down. And then I think they'll be more appreciative if they understood the need to take this seriously, to respond to them. In the past, I've actually responded to real codes where it was custody officers. I had custody officers who were diabetics who had hypoglycemic attacks. And so they were very appreciative of our quick responses. Intake. So if your facility is like a county jail or a intake facility in the prison system, you need to really make sure that folks are being treated properly and timely with intakes. There's certain timeframes that you're held to, and so you need to make sure that your staff are appropriately meeting those timeframes and checking off whatever boxes and referrals need to be done to mental health or the first chronic care visit, making sure their medications have been verified and ordered so that they get them timely the next day. So those are all important things medical directors should stay on top of as well. So culture. As I was saying earlier, you need to be the role model. And by role modeling and being firm, fair, and consistent, and being also attentive and listen to custody, and not be so rapid to want to kind of be defensive and push back. Sometimes you need to understand where they're kind of, their job is public safety. It's to make sure that the operations of the facility are ongoing without disruption. And a lot of times they really don't understand what we do. They may see us as ancillary and not see us as partners, but you need to continue to work and build that rapport with custody. I worked in corrections for a little bit over 20 years, but I worked in one system 3 times on 3 separate occasions. And it was interesting for me, which I never really paid attention to, but I started off my career at a women's prison. And I worked there. I didn't really know the officers back in the day, but I just worked with them, and just them seeing me do what I do every day. It was interesting the second time I came back that they were all like, happy to see me again. And it's like, I didn't realize people actually knew who I was the first time around, but people do remember you, and then they help you out. And then the third time I come back, and I was talking to some folks, and then, the people that I used to consider as, officers were now head administrators. And one of them recalled me having a conversation with them in an elevator at the maximum security facility. We were talking about how, you need to do this, you need to understand other things. And somehow that, I don't know how it triggered the officer, but the officer said that it motivated him to actually pursue an advanced degree and got his master's, and then eventually became an administrator, and was very thankful for whatever I said, which I don't recall. But he was a very successful, high-level administrator for the system that I worked at. And the important thing is that we can always educate them. Sometimes you feel like it's futile, but it does slowly sink into them, especially if you're consistent every day. I mean, sometimes you can wear them down because they see that you're going to keep doing the same thing over and over and over again, especially if it's the right thing to do. And eventually they'll ask you, it's like, hey, having that deeper conversation with them may get them to get a little bit more buy-in working with you. And other thing, like I try to avoid is gossip. There's always the scuttlebutt going on. Try to stay away from all that. Be professional all the time. Just stick to making sure patients are taken care of, making sure schedules are working, people are going out for their trips. Don't get into like what's the staff doing, which staff is whatever. I just never really got into it with the nurses and the officers, even though, it was interesting back in the day. On one system I worked at as a regional medical director, the officers actually invited me to actually go deep sea fishing with them. So that was very nice of them to ask me to participate with them on an outing like that. Again, you want to set the culture where people feel comfortable in coming to you as the manager. So try to have an open door policy. Always just listen first. Don't be quick. Sometimes some folks don't really want a quick response. They just want someone to just listen, let them vent. So just, take the time to be able to offer that to your staff. It goes a long way. I remember when I was leaving one system that I used to always sit in the lunch area with the medical clerks and the healthcare record specialists. And when I was actually leaving the system for another opportunity, I was really caught off guard by the staff there saying, they really thought highly of me because the fact that I took the time to sit and have lunch with them and listen to them and just be there, not as their manager, but as someone that they can trust and know that someone's got their back. So that was really nice, the feedback that I got about that. And then also remember, we work in a paramilitary system, and so there's certain things you have to do going through the proper chain of command. And some things we just got to report and make sure that the warden is aware so he doesn't get caught off guard. So if there's anything that's really important, please ensure that the proper people are well informed, because no one wants to be blind. I don't like to be blindsided. So it's courtesy both ways. And again, model professional behavior at all times because everyone's watching you. Certainly the patients are watching us. So best practices, constantly trying to learn and share, be good partners with your coworkers, and not afraid to challenge the status quo. I mean, just because we've done it this way all the time doesn't mean it's the right thing. Things change. Sometimes policy guidelines get updated and now we have to do things differently. Don't be afraid to push back with custody and say, I remember back in, well, I'm going to share that. I know this is being recorded, but I think it's important that I share. So back a long time ago, I actually got a DATA 2000 waiver for buprenorphine. Back then, you had to, actually take a class for 8 hours to be able to prescribe buprenorphine as an outpatient. And the reason why I did that was I was at a system where they actually had no OTP. The judges knew that and deliberately would violate folks as parole violators to the prison system because they knew that they couldn't continue their methadone. They wanted the patients to suffer and go cold turkey into withdrawal. And I thought that was cruel. And so I went about by getting a DATA 2000 waiver and was able to convince the facility to allow me to start prescribing buprenorphine for tapered withdrawal. So I did that. Patients were very appreciative of it back in the day, but word got up to the central command. And so my statewide DOC medical director got a lecture and filtered down, but he ended up supporting me at the end. He asked forgiveness later. So, I mean, nowadays that it's becoming now, the standard of care. You're expected. Otherwise, the Department of Justice is going to come after you if you don't offer MAT. But back in the day, I mean, people thought I was crazy to provide buprenorphine back in 2007. Also, always listen. Just don't be quick to provide commentary or feedback, but sometimes just listen first before speaking. And then this kind of goes into the fact that the legal system, you need to really understand this as a medical director. So with the legal system, first thing you got to know is the difference between medical malpractice and 1983 lawsuits. So with med mal, obviously, we know that, if you did something or, it's negligence and, there's usually a summary judgment of, paying out and it gets a ding on your national practitioners database. And, it could affect your licensure in various jurisdictions. So that's medical malpractice. 1983 lawsuits. These are federal suits around the fact that you're violating their 8th Amendment right or 14th Amendment right if you're working in a jail setting. So those actually don't end up in the National Practitioners Database. But understand that, while that doesn't show up there, it has a lot of effects for your system overall, because it can invite further other lawsuits that may include MedMal as a result of losing to a 1983 lawsuit. Understand that it requires a high bar to say that you violated the 8th Amendment. There has to be medical deliberate indifference. And so I hope as a medical director, you understand what medical deliberate indifference is and make sure that your staff are aware, and so that you don't end up losing these 1983, because it's really hard to lose these things because, like I said, the bar is set really high. But lately in the last couple of years, I've been seeing some significant losses of these cases. Again, be proactive. If you know there are issues in your facility, try to mitigate them while they're small. Like I said, a grievance, file early on. If you can nip it in the bud, please do. Otherwise, it may, end up getting out of your hands, and other people may be involved in it. Documenting, review charts. Like I said, make sure people are documented properly. It's so important because, what you may think is not important today, but maybe 5 years down the road, depending on the statute of limitations of your system, it may come back to bite you for not documenting, because if you didn't document, it didn't happen. So it's really important to ensure your staff document properly. My first significant lawsuit in the prison system, I did intake. So, you don't see these people 2 weeks, they're gone to their permanent facility. But I had a guy who my mid-level provider asked me to take a look at detention because he was a transfer in from another facility's detention. And he was involved in an altercation and had neck pain, and claimed that, he had some neurological changes. So being the medical director and supporting my mid-level, I actually went to see the patient. And I wrote actually a 2-page progress note type of thing, a detailed note in the chart. Back then it was a paper chart. And thank goodness I did that, because I got called 3 years later working in another system across the country that I was being deposed in this lawsuit. And I don't remember the name of the patient. I don't remember anything about him. But fortunately for me, the AG gave me a copy of my note. And so when I was being deposed, literally not even 30 minutes into the deposition, the plaintiff's attorney actually said, "Stop, we're going to drop you from the case. Clearly, you documented everything, and you did everything you could for my client." And off the record, he actually said to me, he's like, "Can I use you as a subject matter expert in future litigation? Because I think you know how to look at a chart and document, and you would be able to find things for me." So the AG actually said that was a high honor coming from this particular plaintiff's attorney. So just something to consider about documenting properly, because again, a couple of years down the road, you're not going to remember everything. And understand everything is discoverable these days. In the past, they just asked for the medical records. Nowadays, the attorneys are getting very savvy. They're asking for emails, texts, logs, any kind of other documentation that's not part of the chart. They'll ask for it. And most of the time you do have to provide it, even though there might be some redactions of certain things, but for the most part, you're not shielded. So please keep in mind that if there's something that you write, it'll be discoverable. For me, I always make sure that I know my counsel folks, keep them abreast if I get named in something. Being a medical director of a large system for a couple of years, I was named because I was ultimately in charge of the whole system. I got named in every lawsuit, even though I had nothing to do with it. But it was good to always have that connection with the AG's office, the attorneys. We used to have this running joke that I would spend half my days in court and also at the AG's office, that they should just give me my own office over there. But having that connection really helped, because a lot of those cases were all dismissed. just the fact that we had a good working relationship. And also, if you haven't been cross-examined or deposed before, I would suggest that, you listen to Dina Johnson if you ever have a chance to hear her speak. She's wonderful as a subject matter expert in legal defense. So it'd be worthwhile for you to ever, attend an NCCA conference where she's presenting, just to know how to deal with cross-examine and depose. Understand we are the expert, and they're going to try to do everything to make us lose our composure and to say something that we didn't really mean to say, or it makes us sound like we're not so knowledgeable. So understand you don't need to rush to say anything. Take your time thinking about what you want to say, and you can always ask them to repeat the question. Understand that their motive is to really ask you the same question over and over in many different ways, and you get so frustrated because, like, I already told you that. Don't ever fall for that. Okay, just relax, keep answering, and be consistent. And again, lastly, just be aware of any kind of consent decrees and some agreements that your facility may have, because again, you need to develop that rapport with the monitors, and ultimately your goal is to make sure patients are safe and taken care of, but you also have responsibility of trying to help in any way of sunsetting some of these old consent decrees and settlement agreements. And lastly, this is just my personal take. We get into these opportunities to be leaders, and we shouldn't be thinking about, well, it's because I want higher pay. It's not worth it. You're not going to be happy if ultimately it's money that you want, higher salary. A lot of times it's more administrative. So understand that clinical time is more valuable, and so don't take it personal if some staff physicians make more than you as a medical director, because the medical director may only have a part-time position versus a full-time position. And again, the need is really taking care of the patients. So keep that in mind. And also, management really should not be a unionized position, but I've worked in a system where I thought that was a little bizarre, and it kind of put my folks in a weird position where my site medical directors were also in a union, but I wasn't, being their statewide medical director. So it was something that we had to kind of be very mindful and careful of, because I didn't want to breach any kind of unionized contract agreements in working with my site medical directors. And at this point, I'll take any questions if anyone has. I know I said a lot of things, but the best thing you can do is to constantly just be fair, firm, and consistent, and be slow to speak up and just listen to everybody. Oh, quiet audience today.
Local hot. Am I heard? Dr. Booth?
Yes, I'm here.
Hello? Yeah,
Yes.
Okay, sorry about it. Thank you. This is Mike Nicky from San Diego County. You mentioned about your regional directors. What is that ratio, and how do you control your medical, how do you communicate with your medical directors at which control each site? And what are that relationship? And is it a call system? Is it a regular meeting that you go through?
Yeah, so your site medical directors usually should have a check-in with, if there is a regional or a statewide medical director, there should be opportunities for them to interact on a routine basis. So when I was a regional medical director of a state prison system, I was responsible for 7 facilities. And so I had basically 5 different medical directors. I was also a medical director for 2 of the facilities. And so I would routinely have personal one-on-one check-ins with you in a quarterly period, but I would also just be available, because like on a weekly call, we would talk about ER runs and say, did this person really need to go out that day, or could we have done something differently and managed them and not send them out as an emergency, but maybe as a schedule to see a specialist. And so once a week, I would check in with all my facilities that I was responsible for, medical directors, and go over all the ER runs that way.
So you mentioned, I don't know anybody else has question, but it's very important that once your clinic is over, for example, that day, like 5 p.m., 4 p.m., whatever, who controls the ER cards after that? Is there a call system? Do they communicate with the physician or just follow your policies and procedures?
So it depends on your system. So when I worked as a statewide medical director for a system where it's a both prisons and jail unified system, we had a call system where there was first call by the site medical directors, and they would get a stipend for doing that. So it would start at 4 o'clock in the afternoon, and it would go on to the next morning at like 8 o'clock. And those folks had to do that because there was a union agreement. They were all unionized, and so they got a stipend for being on call. And then I actually was able to interject with the union and allow me to take 2 days of call per month, just so I'm also familiar with the system as well. And so, but I was also the backup second call. So if the facility wasn't able to reach them in a reasonable time frame, I was always the backup anyways. But other systems do it differently too. I mean, they may have a dedicated night team that handles everything after hours. And some systems, if they're that small, it's really the site. All the providers may rotate in sharing call, but in the systems I worked at were academic stateside. We usually had tier systems, and because the staff were all union.
Thank you so much.
Sure. Any other questions from the audience? I don't know if, I guess I finished a little too early. But
good detailed
Ronnie,
information.
I would like to say that not so much a question, but thank you very much for the presentation. I enjoyed it. And I think that we often overlook, those of us who are medical directors often overlook the importance or the potential legal liability that can come with the medical director title. So, I mean, you need to know what's in your contract, what you're supposed to be doing, et cetera. I mean, I've been surprised at the number of times where medical directors were contracted for something that they didn't know they were contracted for, or at least it's alleged that they were. So in other words, things like training of correctional officers and stuff. So, I mean, I think it's important that we recognize the medical director role as opposed to being a physician at a site.
yeah, it really is 2 different job sets. I mean, just because you're a staff physician doesn't necessarily mean that you can do the job of a site medical director, because it's 2 different things. I had a huge learning curve. I started off my first year in corrections working as a independent contractor, because my group got a contract at the women's prison, and being the junior guy in the group, they said, hey, you go take care of that. So I was a staff physician for a year. And at the time, I kind of just did my own thing, but I also had to, put in non-formulary requests, put in for requests for MRI, offsite stuff, and then have somebody else who was the site medical director and the regional medical review those. And a lot of times I would have to really, really, explain myself because they were just not getting sufficient information. So there's a learning curve. And so that helped me when I transitioned to be a statewide medical director, and having now at the other end being the guy reviewing these requests, that I understand they're frustrated because they're getting a lot of pressure from the patients to say, oh, I need this done. I need this medication. And so, it's a tough place to be for them. And so you need to think of, why they're generating this. It's not because sometimes we think that, oh, just being lazy, or they just don't want to think to do it themselves. But sometimes there's actual real pressure. It could even be custody that's pressuring them to generate it. So just, that understanding of being a staff physician did help to a certain degree with understanding to be able to help support my staff when I was the site medical director. And then the regional medical director, that's a little bit more politics. You're dealing with multiple loyalties at that point, because you need to
Exactly.
keep corporate folks, you need to keep the DOC people happy. And also you got to deal more with the legal folks too. And so it's a lot more of, policy driven. You need to really be up to date with the current things that are going on in your jurisdiction, and be prepared to speak to it or defend it or adapt to it. One of the systems I came back to was that the governor decided that he wanted to make his legacy all about MAT. And so we had to make it work.
Right. Well, thank you very much. I think it was a good presentation.
Thank you. Any other questions or comments or any feedback that maybe suggestions that I could do? Because I'm always trying to learn, because I'm not perfect. I make a lot of mistakes, and I admit that. So I think, my staff appreciates the fact that I don't always know anything, but I'm willing to learn. And so if there's any feedback you have for me, I greatly appreciate it as well.
Just a comment, not feedback. I mean, you have more experience than I do, but the way I came in, actually, I came from training to medical directorship. So I did officer training at the beginning. But what I realized was that the nurses that I had for locations were all wide variety of experience. They would have come from psych, and I had no idea what the trauma is, what the female pregnancy issues is. So what I did for the past 10 years is I started once a year, one day, half a day, I'll do a presentation, group of presentation related to most common cases that we deal with: diabetes, trauma, orthopedics care, all these. And I find out that actually you get less call, less emails when their confidence level goes in. And fortunately, knock on wood, we didn't have any adverse event ever since I started it. Prior to me joining that group, they had femur fracture that was missed and displaced, but the kid was complaining about the pain and never went to ER. Shortness of breath that ended up being PE, which I had to take care of it in the ER side when I was back there. So that was interesting. But this is what we do right now, like Narcan training for officer, Narcan training for disaster management. And that's part of what Tom was mentioning too. You're basically doing both sides of the venture here. Thank you again. Wonderful.
Thank you, Michael. I certainly agree with you. I mean, education goes a long way, and it makes, at the end of the day, it makes your life easier when everyone, knows what they're responsible for, and so it just makes things flow so much better.
Johnny, hi, it's Arthur Brewer. Can you hear me okay?
Yes.
Yeah, I'm so sorry. I was looking forward to this, and I kind of lost my mind. Fortunately, I found it a few minutes ago, so I was able to join late. But no, it was an excellent presentation. I think you really covered the salient features about the importance of our job. And again, I appreciate what you've said. I was looking forward to hear it, and I'm sorry I missed. I came in at about 7:45, whatever. But no, good job. There isn't anything I think that you would need to add. I think you covered all of the challenges, and as always, you're respectful and considerate, and are always looking for opportunities, and that's been my experience working with you, and that's clear that that's your experience as a person. So thank you for sharing that. I appreciate it.
Thank you, Arthur. That means a lot. So for those of you who don't know, I worked with Arthur for a long time. So he's actually my mentor. I learned everything from him. So he has a way about making you feel comfortable in doing your job and not get so stressed out. And he was always willing to listen to me, because I certainly was in his office quite numerous times.
Yeah, that's true, but that's what we're here for, and I appreciate your work in the past and certainly what you're doing now to move us forward. I really do. Thank you.
Thank you. So Susan, if there's no other questions or comments, I guess perhaps we can close this. I don't know if there's anything you needed to say or anything.
I am, Johnny. I always like to have the audience talk and I like to listen. And, we can never get enough of you talking. It's always a true privilege and honor. Dr. Folks, Tom, you raised your hand. You want to unmute yourself? I saw.
No, I was just going to say good night, everybody. And I'm enjoying this. Let's keep doing it. So, no, I didn't have anything to say. I was waving goodbye to everybody. Good night. See y'all.
Thank you so much. Have a good night.
Good night, everybody.
Good night.